Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Health Insight, and I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They are brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. In honor of Pain Awareness Month, our next 3 events will feature a special educational series on pain. We are very excited about today's presenter, who was brought back by popular demand, Julie Foster, who's going to be talking with us about pain, behaviors, and dementia. So Julie graduated from George Mason University with a BSN in 2007. As a nurse, she worked on an inpatient cardiac unit and then as a clinical research coordinator for a trauma infectious disease study in Landstuhl, Germany. She graduated from Georgetown University with her Master's of Science in Nursing as a family nurse practitioner in 2015. Since then, Julie has worked for the Southwest Center on Aging, which is a geriatric practice in Las Cruces, New Mexico. Now, Julie is currently working with Mesilla Valley Hospice, doing palliative and hospice care as well. I will now turn things over to Julie Foster. Julie, you may get started.
What we know about pain, as far as there's many different types, many different cause it. Each individual sort of experiences it differently, so different patients have different pain thresholds. Limited pharmacologic tools, so we only have a set number of medications or treatment modalities. And that pain, we know specifically with geriatrics, specifically with patients with dementia, that pain is a big component to the poor overall quality of life. Next slide. So just as a review, just kind of as a framework, there's different types of pain. So nociceptive, which can be somatic or visceral. So the somatic is that really stereotypical, just kind of musculoskeletal. It's localized, it's easy to identify. Think like osteoarthritis when you're thinking that. The visceral pain, specifically with dementia patients, can just manifest as they're uncomfortable. They might not be able to tell you. It's usually kind of from the internal organs. So think of abdominal pain, gallbladder pain. It might be referred. They might not be able to tell you exactly where it hurts. Neuropathic is that classic burning, tingling, shooting. Sometimes they'll just say it feels hot. Sometimes they'll actually even say that it itches, but they're really talking about something that's pain, and it's very difficult to treat. Functional, which is kind of a set of disorders, very difficult to treat. That's a whole presentation in and of itself, but that's more like the fibromyalgia, IBS. And in this population specifically, chronic cystitis is one of them. And then psychosomatic, and that's not just saying, hey, you know, the pain is in your head. It really is. It's from a mental or emotional disturbance, but it really does cause a physical response. So think about chest pain as opposed, like when it's coming from someone who's very anxious, they actually manifest as chest pain. Next slide.
Julie, I'm sorry to interrupt. I'm hearing from folks that you're cutting in and out just a little bit.
All right, let me see if I can move forward. All right, let me know. Is that any better? Yay, nay?
Yes, I believe so. Thank you.
You're just gonna face closer, sorry. So I think it's hard with patients with dementia. I know it can be very overwhelming. There's a lot going on. There's a lot that we can't control. So we can't control the family dynamics. You know, you have patients that have family members. Maybe you have multiple family members that are POAs, and there's that one that wants you to treat them. There's the other that's like, oh my gosh, no medications. We can't change that. We can't change the course of their disease process. So where they are in the dementia process, there is no cure. So it's very difficult. The level of comfort of your providing the prescribing provider. So whether it's the medical director, the PA, the nurse practitioner, whoever their primary is, we're not going to be able to change how comfortable they feel with certain medications. We can't change their comorbidities, and we can't change how they specifically deal with pain. So especially if we're talking about somebody with dementia, they're 80-something years old, We are not going to change that patient who has always had a very low pain threshold, who's always been very sensitive to pain. We're not going to change that. So we cannot control that. Next slide. But there are things that we can control. So we can control how we react. So that's just kind of that gut check of, is this behavior truly worse today? Or is it because I'm having a bad day? Is it because I'm in pain? Is it because I just, I didn't get sleep or whatever? So doing that gut check, that are we projecting a little bit, or is this truly about them? How we communicate with the family, how we communicate with providers, we can control that. Eliminating identifiable triggers or treating some of the reversible conditions, and then environmental changes. We can control those. Next slide. So this is kind of a review. This was kind of listed in the last presentation, but it's an important that address the things that we can address. So the reversible identifiable triggers, things like infection. So if the pain is being caused by something infectious like a UTI, I think another big one that is sometimes overlooked is urinary retention, specifically in this population. Really pay attention to their urinary output. Are they retaining? Because that will make their stomachs distended. It'll make their behaviors a lot worse. They're not always able to verbalize it either. Constipation is another big one. And then drug induced too. Just always looking at the med list and seeing, are we causing some of these, there are medications that might actually be contributing to the pain or to the behaviors. And the psychological and environmental components that we can change, that we can fix. So are they lonely? Are they frustrated? Are they, did we disrupt their routine? Did they just come back from an ER visit or a hospitalization and their routine is completely messed up? Inappropriate lighting, really noisy environments, all of those things that we can identify and potentially change right then and right there. Next slide. So the non-pharmacologic treatment options that we can actually implement. So I always kind of laugh when there's suggestions, and one of the suggestions is always like acupressure, acupuncture. Now, I think it's a great option. If you have it available to you, you're fancy, that's awesome. But for most of us on like skilled units, ALFs, that is not a viable everyday thing that you can do to change that doesn't involve giving meds. One of the biggest ones is sit down. So research has been done on this over and over, that patients' perception of the amount of time that you spend with them when you are physically sitting down compared to when you are standing up, they perceive that when you were sitting down, you were spending a lot longer amount of time. Even if you actually spent more time with them standing up, just by sitting down, it's incredibly comforting. Music, I would have loved to have had time to include in this presentation. There's a great little module on YouTube, but it's from a memory care unit, and it's just how they implemented this music program. And it's not just about bringing people in to kind of local people to do music, which is great. It's actually, they had family members bring in iPods or phones that had music on it. And you can see that some of these patients with moderate to advanced dementia that are completely withdrawn, when you put those headphones on them and it's music that they were familiar with, that they actually have, memories of from when they were younger, you can just see them become a little bit more engaged. And it's a good distraction technique. And you know what, even if it's for 10 minutes, you're distracting them from pain for 10 minutes and improving their quality of life. Quiet environment, but not necessarily alone. We don't necessarily want to isolate these patients, although sometimes that does help. Sometimes just putting them with another non-intrusive resident can help, where they don't feel like they're alone. Light massage. So some units have contracts with massage therapy schools, which is great. It's another great option for pain relief. But I don't know if you guys are familiar. I know in palliative care, you don't see it done quite as much, but like the ABH lotion, it's Ativan, Benadryl, Haldol. It used to be used, I think, a lot more. Anecdotally, I think nurses used to find that it actually helps. So they would just, rub the topical on there, and they felt like it helped calm down the patients and help with pain and help with behaviors. When they actually did testing pharmacokinetically, they couldn't find any level of some of those drugs in the in the person's bloodstream, I think, except maybe the diphenhydramine. So I think they could find the Benadryl a little bit, but not the Ativan or the Haldol. But what they are finding is that possibly what actually is helping is kind of those pressure points and just the touch. So that's something that you can do. It's just, you can actually have a family member do, you can have anyone do, just light massage, that does help. And then reposition and relocate. Just reboot the system, get them up, move them to a different location. Sometimes that is enough, specifically with dementia patients, just to kind of distract again and kind of reboot the system. Next slide. So what we're actually going to focus on a little bit more is areas where you can make a difference. So this isn't, specific pain treatment modalities, but areas where you have this unique opportunity, being with the patients all the time, seeing the family members a little bit more than the providers, to kind of areas where you can influence. So it's deprescribing, being a liaison between the family member and the provider, simplifying the goals of care, managing expectations, which is huge, and starting end-of-life discussions. Okay, next slide. So deprescribing, as providers, we're great at throwing meds at patients for different things. Sometimes we're not so great with actually going back and taking other medications off. But deprescribing is the process of discontinuing, tapering, or reducing a medication just to reduce that overall pill burden and just improve quality of life. Really, ideally, this should be a conversation between everyone. Like, it shouldn't just be a provider coming in and just taking off medications or slashing them. It really should be a conversation between everyone involved, specifically with the family too. And it's a process. It doesn't have to happen just immediately or just all the medications are discontinued, but kind of over the course of a couple different visits. One of the reasons that I think this doesn't happen is it can be very time consuming. It does require a lot of education with the family members and with the patient. Next slide. And these are just some possible recommendations. These are the things that just me personally, when I go in and I'm looking to, because I am a firm believer that the least amount of medications is probably the best. These are some of the first ones that I look to start getting rid of, especially if we are going to more aggressively treat for pain, treat for agitation, treat for sleep. That means we're adding medications. So let's get rid of all the other ones that we don't necessarily need or that are no longer really benefiting this person and they're really not helping their quality of life. Also, like specifically statins, that's something that can actually contribute to myalgias and body aches. So starting to look at tapering those down, getting those off. Dementia medications, they can cause nausea, they can cause vomiting, they can cause diarrhea. All of these things contribute to just overall poor quality of life in these patients, and there really is limited support to use these, especially with moderate to advanced dementia. And just some other ones are like the anticoagulants. Antihypertensives is another big one. A lot of these patients are cardiac patients that have a ton of blood pressure meds. They can contribute just to fatigue. They also contribute to falls. PPIs is another one that they can contribute to infection and osteoporosis, which obviously increases their fracture risk. Vitamins and supplements, if they're eating well, a lot of times those are things that family members feel very strongly about, but if you can get them off, even better. And any PRNs that just aren't being used, just get them off more. Next slide. So communication and treatment goals. I think one of the most important things is really finding out specifically what is the most important thing to the family member or to the patient. I mean, really it's all about the patient, but when we're talking about advanced dementia, they're really not the greatest historians. And so a lot of times we are dealing with the POAs and the family members, but what are we really looking to treat? What is the most important thing? And specifically, like, the pain is interfering with their sleep. This is what's super important to them. Also, finding out what is tolerable versus very distressing. So really finding out, what will it look like when we control the pain? What is that going to look like? Does that mean that they're not going to cry out in pain every time we move them? Does that mean that they're ambulating again? Does that mean that their appetite is increasing? Because all of those things, some of those things that they have in their head is, what is the end all goal? That might not be the most realistic thing for this patient. So it's a great education opportunity as well, just to discuss their overall like progression in their disease process. But it's just important to kind of get what their goals are. And then asking their opinion. I mean, maybe this person never took medication in the past, or maybe they did, or maybe they used, you know, hot compresses or cold ice packs. That's what they used to use when they were younger. So if you can kind of find out what they used to use, sometimes that also will help. Next slide. So simplifying goals, and I think really important, I think you have this opportunity to really start managing their expectations. So determining the most distressing thing to them and focusing first on that if possible. And I think everyone needs to understand that this is a process. This is, I mean, unless it's something that's just very acute, very short term, this is usually not something that we should expect to fix with one medication change or with one pill. And also just finding out again what the goals are. If our goal is no pain ever and totally pain-free, or the fact that this person is no longer ever going to have behaviors, we're going to fail. So again, I think it's taking that time to find out what it will look like when they're treated, what that looks like, and communicating that with the provider, communicating that with the family, everyone being on the same page. I think that helps. And there's no medication that doesn't have any possible adverse effect or risk. And that has to be a team approach as well. So there are some family members who you will say, you know, we're going to start this medication and this might make them a little bit sleepy. And they're fine with that. They think, okay, if my family member, if my loved one is a little bit sleepy, that means they're comfortable, they're resting, they're not in pain. That's the most important thing to me. And there are others that will absolutely freak out if they come on and they come to visit their loved one, or even the patient, if they are tired and they are sleeping and they're sleeping throughout the day and maybe they miss a meal or two. That is completely unacceptable to them. So really finding out, and then we have to decide as a team. So we have to figure out what's going to be the best treatment option for them, because that means that we're going to probably have to go with a different medication. And let the family and the patient know this is going to take time. It really is. It takes time. It takes trials of different medications, takes adjustments to get them to that tolerable level, and that you will be persistent. So knock on wood, I would say that to date, I have not yet had a family member, even the quote unquote high maintenance ones, that are very concerned. I have yet to have someone come back and be absolutely frustrated. If we sat down and had a discussion about the fact that, you know what, this might take a week or two for this to kick in, this might not even work at all, but this is what we're going to try. Are you on board with this plan? And if this doesn't work, we will go to plan B. And here's what I'm thinking for plan B. And if that doesn't work, we'll go to plan C. Most people just want to be involved, both the patient and the family. They just want communication. And so I think if we can kind of give them that assurance that we're not going to give up, like I said, to date, that alone has helped immensely. I think with their perception of pain too, they don't have as much of that hopelessness and the depression when they feel like it's actively being worked on. Next slide. And then also reminding, providers are people too. So I think sometimes if you're in the position of kind of advocating for your patient, or you're advocating for the family and the patient, and you go to a provider and they don't want to do anything, sometimes it's just not been presented maybe at the best time. And I think it's one of the biggest things is that pain management as a whole, it should be ideally actually a very lengthy visit. Usually it's a pretty complex process. You're having to really look at a whole bunch of other things. There should be a chart review. There should be a medication review. So providers know that that's going to take them a long time. So if possible, this is not an on-call kind of call them after hours or that sort of thing. It really should be the thing that they addressed in that visit, not addressing anything else, but let's focus on this today. And then the reality is that like the opiophobia. So that's a huge thing that providers are getting hit with the DEA, with the Board of Pharmacy, with the different regulations. I mean, even now, I think CVS in a couple different states has limited the amount of opioids. It doesn't matter what a provider prescribes. I think they will only dispense a certain amount. So providers are kind of dealing with all of that with this whole opioid crisis. And so they're requiring a lot more reason to actually prescribe opioids, especially with dementia patients, especially with geriatrics, than previously. And then paint the picture. Don't worry about, I know we kind of discussed pain AD and some of the different pain scales in the past, and it's hard. It's really hard, especially with advanced dementia patients. I personally, I would not worry that much about pain scales. I know different facilities have different criteria and things that they have to use. In general, though, I would say we will not go wrong if we focus on specific functional. So how it is affecting them functionally. If you're documenting how is this actually impacting them, they're no longer ambulating to meals. They are no longer eating 100% due to the pain. They are no longer able to do this ADL independently because of the pain or because of the complaints of pain. They are no longer sleeping throughout the night. Those kind of things, I don't think anyone's ever going to come back and say you didn't address pain correctly if those types of things are being documented. And actually, when I'm doing my documentation, I feel like that is way more specific. I think it's way more just effective with documentation wise to do that, other than saying, oh, their pain is an 8 out of 10. So next slide. And so just setting yourself up for success. And you can go on to the next slide too. I'd included this in the previous. You can go to the next slide. There we go. I'd included this in the previous one, and this is just kind of a guideline, just helping if you do have medical directors or providers who are kind of reluctant to prescribe, just how to sort of frame it to them. Again, thinking functionally about what's being affected, like, oh, really, we have to treat this. They're not sleeping, they're not eating, very specific, and very specific about how things aren't working. So this is the medication that they're on right now. We're having to use this PRN this many times a day. It's no longer working because they are doing this or they aren't doing this. All of those specifics are hugely helpful, especially when you're trying to present it to get the pain treatment plan changed. You can go to the next one. And that's just additional things to include. And the next one, okay. So starting the end of life discussion. Included in this just because for the bigger picture, specifically with dementia patients, dementia is a life-limiting illness. So we don't have any current curative treatments. And so we need to start looking, I think, at managing really their symptoms, which is what we're talking about. We're talking about managing pain and managing anxiety and restlessness and appetite and sleep and all of these things. We're not going to probably cure what the actual problem is. So we're really just doing symptom management. So ideally, if you have the opportunity to start discussing this with families sooner rather than later, because it's just the pain management plan, their overall plan of care is something that I think we don't always start addressing soon enough. I think we do it kind of when there is an issue, when there was a, an ER visit or an acute illness, or in sort of a crisis situation. But if you have the opportunity to start having these discussions with them, and the segue might be discussing their pain, take that opportunity, start talking about it, start talking about their DNR status, what their wishes are for them. Do they want them to have a feeding tube? Do they want them to be, mechanically ventilated? Because when you're looking at pain management, and we're really looking at pain management with dementia patients, we also have to think it's not just their acute pain or the pain that they're having right now, but also avoiding needless pain. So avoiding needless surgical procedures and aggressive interventions and treatments. That's also part of the whole plan. So really focusing on their quality of life with the family. And it really does take a team approach. I think it takes everyone. It's not just It's not just the provider, it's not just the nurse, it's not just facility, administrators, it's not just hospice. I think everyone kind of has to be on the same page. And so reaching out to palliative care, I don't know if you have in your areas have palliative care teams specifically, not just, and this doesn't just have to be hospice, and they might not be ready for hospice, but many times those providers have a little bit more time than primary care providers to have those conversations, so that if you're having a patient that is having a difficult time getting their pain managed, and maybe the PCP is a little bit reluctant to kind of do anything more aggressive, really consider reaching out to these people, because they might have good suggestions, and they're also kind of considering the full picture too. Next slide. So again, just things to consider. What are we really trying to treat? So really focusing on what is the most important thing to the patient. So if they are able to tell you, what is the most important thing? Is the most important thing the fact that they're really not sleeping? Is the most important thing that they really hurt and they're not able to walk anymore? But it opens up that conversation so that we're digging a little bit deeper, so we really can treat what's most important to them. And then also just avoiding the painful disruptive treatments and invasive procedures can also be part of this pain management plan. So again, bigger picture, especially with advanced dementia, it's so disruptive to them to have to be sent out to the emergency room, have to be sent out for these extended hospitalizations. Let's really try and treat what we can in their current environment, whether that's assisted living, whether it's skilled nursing, whether that's at home, wherever that is. And then just knowing a few quality resources to provide to family members. I can't tell you how many of them come back and they're talking about different treatment approaches from I was on this forum talking to this person, and that's great. It's great emotional support. However, unfortunately, a lot of times the recommendations that they're getting from these other family members are not medically sound. They might not be the most evidence-based. And so instead of being able to sit down and talk to them about treatment plans that might actually work, I actually spend a really long time trying to tell them why this won't work and why this is not a good plan. So if we can kind of preemptively give them actual good medically sound evidence-based resources, like from the Alzheimer's Association or from the palliative care, your local palliative care or hospice group, if we can provide them that preemptively and give them that to look at, that actually can save a little bit of time where we're heading down the wrong path with them, where we're having to tell them why certain things are not good ideas. But all right, next slide. So I tried to get through that. So if you guys have any questions.
And while you're thinking of your questions, I'm going to just quickly put in where you can find our previous hot topics, including the part 1 session that Julie did back in July. July 27th is the date, so please check that out if you missed that the first time around. We did have a couple of comments and questions in chat, so I'll read them to you. But again, if you need to jump off, please feel free to do so. But if you could stick around for a few minutes for any questions, that would be great. And please either raise your hand or let us know in chat what those might be. So Sherry mentioned a couple of things. She had mentioned music and memory, and I know you mentioned music, Julie. Is anybody doing that in facilities for pain management? I know a lot of folks are doing it for kind of agitation with folks with Alzheimer's disease. Do you know of anybody using it for pain management at the present time? No? Okay. And then the other question was, what do? You mentioned the case of the family that has very different opinions on what level of medication versus alertness for families. What do you do in the case of that kind of a family? And the example Sherry gave was a patient with bone cancer, yet the family only wants Tylenol and the patient is screaming in pain.
That's so hard. So one thing I do use a lot in hospice is dexamethasone. It's kind of a wonder drug as far as, at least with palliative care. Yes, for maybe your patients with that aren't so far along in dementia or aren't so in stage, it can have a lot of side effects, but it's a it's a non-opioid. It doesn't make them tired. It actually gives them energy. It helps with pain. It sparks their appetite. It's like the wonder drug. So for for that specific patient, I would kind of say, let's try some dexamethasone. Let's try that. But it's hard. And those kind of families are very, very, very typical. I get that a lot, especially when it comes time for palliative care and hospice care. They do not want to use morphine. And, they don't want to use morphine. They don't want to use oxy. They don't want to use any of the opioids. The hard thing is you're watching their loved one in pain. You know that there's probably things you can do, but you just have to keep meeting them where they are. So it's just about really listening. And I think most of the time, I won't say every single time, most of the time after talking to them about what really trying to boil down, why don't they want that specific medication? So what is their big fear? What's your fear if we give them this? What is your fear? What are you worried about? And kind of talking through that, a lot of times we are able to kind of come up with like a trial. Sometimes they'll be willing to do just a trial to see how they react. But unfortunately, that is a hard thing. It's really hard when you have one family member that really wants you to medicate them and they can't stand to see their mom in pain, and then you have another one who's like, no, you can't give them anything. It is hard. But usually sitting them down and really boiling down what their huge fear is. And again, it takes multiple visits. That usually doesn't happen in one visit. It usually has to happen over the course. But that's what's great is if people in in the facilities are also having that conversation, because they really trust. You're the ones who see the patient all the time. You're the one who sees them a little bit more, and you usually have a much better relationship with them than the provider who's coming in kind of sporadically. So if they're kind of hearing the same thing from multiple people, that also tends to help. If they're hearing the same message over and over again from multiple people, that can kind of help reinforce.
Definitely. And if you don't mind my chiming in, as a former ombudsman, that's a group that you could definitely get involved in those kinds of situations, because they're an outside party. So I would recommend you contacting your local or state ombudsman in those situations. Skitch mentions that National Healthcare Decisions Day is coming on April 16th, 2019, which is a great opportunity to educate people about their end-of-life decisions. Sherry mentions back to that situation that in that case, the family said the pain was related to psychiatric issues.
Oh, bone cancer? Bone cancer is so incredibly painful. I don't think that was psych, but you can always sort of redirect them in the sense of, okay, so if it's coming from psych issues, then let's address the psych issues. Yes. So, yeah.
So please let us know, take another 30 seconds or so if you have any final questions. Again, what I did is entered our website into chat for those of you who might want to take a look at some of our previous hot topics for your use. Please go ahead and do so. Use them for your staff in-service education. I am not seeing any final questions, so I'm going to release you all back to your day and say thank you very, very much again to Julie Foster, who did a wonderful job once again, and we're grateful to you. Thank you very much to everybody who was able to attend our half-hour Hot Topics. Our next session is actually going to be on October 5th and involving the physical therapist's role in pain management. So please join us again for that. So thank you very much. This concludes our Hot Topic sessions for today, and enjoy your weekend. Take care, everyone. Bye-bye.